Hello, everyone. So, good evening to all of you. So, in this section, I'll be discussing the valvular heart diseases, which is one of the very important topic. So, I'll be doing the comparison of the valvular heart disease, that is the mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. And following which, we'll be doing multiple choice questions on the topic of the valvular heart diseases. So, before going on to that, you need to know what is the Right. So before going on to that, you need to know what is a normal mitral valve area. So normal mitral valve area, so this is around 4 to 6 centimeters square, and normal aortic valve area, it is 3 to 4 centimeters square. Now, when we are using this terminology, that is mitral stenosis, what will happen to the valve area? Valve area is reduced to less than 2 centimeters square. That is what is your mitral stenosis. Now, depending upon the valve area, in case of the mitral stenosis, we classify the mitral stenosis into the progressive, then severe, and then very severe mitral stenosis. Now, in case of the progressive mitral stenosis, right, in case of the progressive mitral stenosis, the valve area, it is right, in progressive mitral stenosis, the valve area is 1.5 to 2 centimeters square. Whereas in case of the severe mitral stenosis, the valve area is around 1 to 1.5 centimeters square. Whereas in case of very severe mitral stenosis, the valve area is less than 1 centimeter square. Okay. So this is how we classify we assess the severity of the mitral stenosis depending upon the valve area. Now, among all these, what is the most common cause? The most common cause for mitral stenosis will be rheumatic heart disease, right? Rheumatic heart disease. Okay. And apart from this, we have some connective tissue disorders like the systemic lupus erythematosus and as well as the rheumatoid arthritis. Then we have some storage disorder, that is the Hurler syndrome. It is a lysosomal storage disorder. And the other etiologies which will be causing mitral stenosis will be the mitral valve calcification and a congenital disorder where you have the formation of a false membrane within the left atrium, and thereby it appears that there is mitral stenosis. Okay, so there will be formation of a false membrane within the left atrium, and that gives that there are 3 atria. And that false membrane which is formed in the left atria will cause narrowing of the mitral valve orifice, and that is what is called as the cork triatrium. Okay, so this will be the etiologies that will be causing mitral stenosis. Then what will be the clinical features that you will have in patients with the mitral stenosis? In patients with mitral stenosis, the left atrial pressure is elevated because left atria is not able to send the blood into the left ventricle, right? So what the left atria will try to do, it will try to increase its pressure to push the blood from left atria to left ventricle. But consequently, as the left atrial pressure is elevated, there will also be increase in the pulmonary venous pressure, subsequently pulmonary capillary wedge pressure, and that will cause pulmonary edema. And because of pulmonary edema, these patients will have dyspnea. And why is that they will have palpitations, right? Palpitations is due to left atrial enlargement. So as and when there is left atrial enlargement, the enlarged left atria is arrhythmogenic. And that enlarged left atria, which is arrhythmogenic, it will cause the atrial fibrillation. And because of which these patients will present with palpitations. And whenever there is atrial fibrillation, when you palpate the pulse, these individuals, they will be having irregular rhythm. Right? They will be having the irregular rhythm. So these two are the important clinical manifestations. Initially dyspnea, and once there is left atrial enlargement, then the individual will have the palpitations due to atrial fibrillation. And on examination of the patients with mitral stenosis, they will be having tapping type of the apical impulse, right? And where is that you will feel for this tapping type of apical impulse? See, even in a normal individual also, it is tapping type of apical impulse. Even in patients with mitral stenosis, it is tapping type of apical impulse. What does that mean? It means that in patients with mitral stenosis, left ventricle is not affected. So all the chambers, they get affected in mitral stenosis except left ventricle. There will be left atrial enlargement. Subsequently, there is increase in pulmonary capillary pressure, and subsequently there is also increase in pulmonary artery pressure that will cause RV enlargement and even RA enlargement. But LV enlargement will not be there, or LV is not affected in case of isolated mitral stenosis. All right. Then coming to this apical impulse, it is felt in the left fifth intercostal space in the mid-clavicular line. Right, left fifth intercostal space, mid-clavicular line. Okay, and it is a tapping type of apical impulse, which is normal apical impulse. Now, these patients will also have the left parasternal heave. Now, what could be the reason for this left parasternal heave? The parasternal heave, it is secondary to right ventricular hypertrophy. Okay, left parasternal heave, it is secondary to right ventricular hypertrophy, because these patients, they develop pulmonary hypertension. Right, they develop pulmonary hypertension, and secondary to pulmonary hypertension, there will be right ventricular enlargement, and there will be right ventricular hypertrophy as well. Okay, so this is about the examination findings that you will have in patients with the mitral stenosis. Next, coming to the auscultation. The first heart sound, it will be loud in patients with mitral stenosis. And at this point, I'll tell you all the conditions where you will have loud first heart sound. Loud first heart sound is heard in all the hyperkinetic states. That is anemia, thyrotoxicosis, beriberi, AV fistula, pregnancy, Paget's disease of bone. In all the hyperkinetic states, the first heart sound will be loud. The other conditions where you will have first heart sound being loud is in case of the MS and TS. And apart from that, those conditions where there is short PR interval, you will have loud S1. Okay. Now, P2 also will be loud in patients with mitral stenosis. What is the reason why the P2 is being loud? That is because of pulmonary hypertension. These patients will have the P2 being loud. And the murmur that you will have is a mid-diastolic murmur. And the mid-diastolic murmur that you will have in patients with MS, it is a low-pitched mid-diastolic murmur, and it is heard at the apex. And there is no radiation of this murmur. Right? There are two conditions where you will have a mid-diastolic murmur. One is in MS and the other one is in TS, tricuspid stenosis. Right? Now, apart from this, okay, so apart from this, there is, or there can be functional mid-diastolic murmur also. Functional mid-diastolic murmur, it is observed in Carey-Coombs murmur. Right? It is observed in, or it is heard in the Carey-Coombs murmur. Okay, and this Carey-Coombs murmur, it is the feature that you will see in case of acute rheumatic fever, right? Acute rheumatic fever causing acute MR. And the other conditions where you will have the functional mid-diastolic murmur is, functional mid-diastolic murmur is also heard in, or it is also observed in Austin-Flint murmur, right? And Austin-Flint murmur, it is observed in the severe AR. Okay, so these are the two conditions where you will have the functional mid-diastolic murmur, whereas true mid-diastolic murmur is heard in the mitral stenosis and as well as the tricuspid stenosis. All right, and it's a low-pitched murmur in case of MS, and it is heard at the apex, and there is no radiation of the murmur. Because it's low-pitched, we listen this murmur with the bell of the stethoscope, right? With the bell of the stethoscope. Okay, next, then you will have opening snap. Opening snap is another important additional sound that you will have in patients, and this opening snap, it is heard in the early part of diastole. Right, opening snap, it is heard in the early part of the diastole, right? And in the mid part of the diastole, you have this mid-diastolic murmur, which is a low-pitched murmur, right? Then followed by that, you have presystolic accentuation. The word PSA stands for the presystolic accentuation. Now, what is the reason for, or what is the mechanism of the presystolic accentuation in mitral stenosis is, this is due to, right? So this is due to strong left atrial contraction. Right? Strong left atrial contraction. So due to strong left atrial contraction against the stenosed mitral valve, you will listen the presystolic accentuation. Okay. So this is about the auscultation in patients with MS. So first heart sound will be loud. But there are certain scenarios of mitral stenosis where the first heart sound can be soft. In which scenarios? Like for example, if the mitral stenosis, if it is a calcified mitral stenosis, then you can have soft S1. Then you can have soft S1 if it is a calcified mitral stenosis. And in S2, what is that we have discussed? we have discussed that the P2 will be loud. And why the P2 is loud in patients with mitral stenosis? That is due to pulmonary hypertension, right? Then, how will you assess the severity of the MS based on the auscultation? Based on auscultation, we just see what is called A2OS gap, right? We listen what is called the A2OS gap. If the A2OS gap is narrow, then it is considered as the severe mitral stenosis. If the A2OS gap is, we consider it as mild mitral stenosis. Then we consider it as mild mitral stenosis. Okay, so this is what is, and the other way by which you can assess the severity of the mitral stenosis based on auscultation is by listening to the duration of the mid-diastolic murmur. Right, by listening to the duration of mid-diastolic murmur. Now, if the duration of mid-diastolic murmur is long, then it is severe MS. Right, if the duration of mid-diastolic murmur is short, then it is mild MS. Right, then it is mild MS or progressive MS. Okay, so based on these two parameters, we can assess the severity of the MS. That is based on the A2OS gap and as well as the duration of mid-diastolic murmur, right? So this is about the auscultation. First start sound will be loud, and first start sound can be soft in case of MS. If it is a calcified MS, the loud P2 will be there. That is due to pulmonary hypertension, and mid-diastolic murmur, which is low pitched, which is heard at the apex, and that is heard with the bell of the stethoscope. And you have the opening snap and then pre-systolic accentuation. And this A2OS gap and as well as the duration of the mid-diastolic murmur, they are the one which will assess the severity of the mitral stenosis, right? Then, how do you work up the patients with the mitral stenosis? Just 1 minute. Okay. So, how do you work up for the patients with the mitral stenosis? The first line investigation is the 2D echo, right? Now, what is all that you'll observe in the 2D echo? In patients with the MS, in 2D echo, we check the valve area, right? We check the valve area. Number 2, we assess the gradient across the mitral valve. And number 3, pulmonary artery pressure. Number 3, pulmonary artery pressure. So when do you call it as progressive MS? When the valve area is 1.5 to 2 centimeters square. When valve area is 1 to 1.5 centimeters square, it is called as severe. And if the valve area is less than 1 centimeter square, it is called very severe. Then, depending upon the gradient across the mitral valve, if the gradient across the mitral valve is less than 5, it is progressive MS. And the gradient across the mitral valve, if it is in between 5 to 10, it is severe MS. And if the gradient across the mitral valve is more than 10, then it is called as very severe MS. And another parameter which will help us to assess the severity is pulmonary artery pressure. Right? So how much is the normal pulmonary artery pressure? 15 to 20 millimeters of mercury. But if the pulmonary artery pressure in MS, if it is around 30 or less than 30, it is mild or progressive MS. Right? And if it is 30 to 50, it is called as the severe. And if it is more than 30 millimeters of mercury, we consider it as the very severe form of MS. We consider it as very severe form of MS. So it is the 2D echo, which is the first line investigation, right? Then followed by that, the ECG. What the ECG will show you, the P wave will be, right? The P wave in the ECG, it is of M shape, right? P wave in the ECG, it is of M shape, and that we call it as P mitral. And what is the duration of the P wave? The duration of the P wave, it is more than 120 milliseconds. The duration of the P wave will be more than 120 milliseconds, right? What is the normal duration of the P wave? Normal P wave duration, right? Normal P wave duration, it is less than 120 milliseconds, but in MS, it is more than 120 milliseconds, right? Next, coming to the chest X-ray. This is the third investigation. So chest X-ray, normally if you take the left heart border, it is not straight. But in patients with MS, you will have a straight left heart border. Then why this straight left heart border? Okay, all these signs, straight left heart border, then double density sign and wide carinal angle. All these are mainly because of left atrial enlargement. Because of the left atrial enlargement, the curvature which is there due to the aortic arch or aortic knuckle, that will get obliterated, right? So left atrial enlargement will make the left heart border straight. And double density sign, it is observed on the right parasternal area. Normally over the right parasternal area, you will have only right atrium. But whenever there is left atrial enlargement, you will also notice the shadow of the left atrium on the right parasternal area. So you will have the shadow of right atrium and left atrium in the right parasternal area, and that will give you double density sign. Next is wide carinal angle. Wide carinal angle. Why there is wide carinal angle? Again, it is because of the left atrial enlargement. So due to left atrial enlargement, they'll have this wide carinal angle. Okay. So this is about the workup. First line will be 2D echo, ECG, and then the chest X-ray. Done. Then followed by that, the treatment. So the treatment in case of the mitral stenosis is that you need to give diuretics plus beta blockers. Why are you giving diuretics in these patients? That is mainly to reduce the pulmonary edema, right? Mainly to reduce the pulmonary edema component, you need to give the diuretics, right? Then followed by that, along with that, you also need to give beta blockers. What is the reason for beta blockers? It is not just because like the individual is developing atrial fibrillation. Even though the individual does not develop atrial fibrillation, we need to give beta blockers in patients with MS. What is the reason? Whenever you give beta blockers, they will reduce the heart rate and it will increase the diastolic filling time. So the left atria has adequate time now when the patient is taking beta blockers to empty the blood from left atria to left ventricle. That is, so in order to increase the diastolic filling time, we give beta blockers in patients with MS, right? Then coming to the surgical treatment. In surgical treatment, you have two options. One is percutaneous balloon mitral valvotomy. The other one is mitral valve replacement. But between these two, which is like more preferable? PBMV is more preferable than compared to MVR. Why? Because the PBMV is less invasive than compared to that of the mitral valve replacement. But this PBMV, it is contraindicated in certain scenarios. In which scenarios? Like if there is left atrial thrombus, there may be rupture of thrombus when you are doing PBMV, where there can be emboli. So left atrial thrombus, PBMV should not be done. Calcified mitral stenosis, the mitral valve can get ruptured, so contraindicated. Then if it is moderate to severe MR, then the PBMV is contraindicated because the MR will get precipitated. Then what is that you need to do in all these conditions? So in all these conditions, that is LA thrombus, calcified mitral stenosis, moderate to severe MR, what is that you need to do is, you need to do mitral valve replacement. You need to do mitral valve replacement. Okay. So this is about the MS, right? Now the MS, whatever we have discussed, we'll try to compare that with the MR, right? MS, whatever we have discussed, we'll try to compare that with MR. Okay. Now this MR, like the basic definition is what, like when the LV is undergoing systole, the blood from the LV will regurgitate back into LA during the LV systole. That is what is called MR, right? So in case of MR, you have two forms of MR. One is the acute MR, right? And then chronic MR. Now, what are the causes for acute MR? If you take mitral valve apparatus, it has mitral valve leaflets, they have chordae tendineae, they have papillary muscles, which are attached to the endocardium. Now, if there is any trauma to the mitral valve apparatus, that will result in the acute MR. If there is any trauma to mitral valve apparatus, that will result in acute MR. Like for example, you take in case of acute MI, it is acute MR. Because in acute MI, you will have rupture of the papillary muscles, that will result in acute MR, right? Then rupture of the chordae tendineae. Where do you have rupture of chordae tendineae? In case of infective endocarditis. So infective endocarditis, this is also the cause for acute MR, right? And the remaining all, like rheumatic heart disease or mitral valve prolapse syndrome, all the forms of cardiomyopathies, DCMP, HCMP, and as well as RCMP, all these are the causes for chronic MR. Whereas infective endocarditis and as well as rupture of the chordae tendineae, infective endocarditis causing rupture of the chordae tendineae and acute mitral regurgitation causing papillary muscle rupture, they are the one which are responsible for acute MR, right? Now, what is the difference between acute MR and chronic MR is, acute MR, it is a very important emergency because acute MR patients, they present with sudden onset dyspnea, right? So, okay, yeah. So if you see this acute MR patients, the acute MR patients, they present with sudden onset dyspnea because they abruptly increase the left atrial pressure because of massive regurgitation. And once left atrial pressure is abruptly increased voluminously, that will reflect back to pulmonary veins and pulmonary capillaries, causing pulmonary edema, and that will result in the sudden onset dyspnea. Whereas you take in case of chronic MR. Chronic MR, it is a mild regurgitation back into the left atria. So there is left atrial enlargement, or you have adequate time for the left atria to get enlarged. So that enlarged left atria is arrhythmogenic, causing atrial fibrillation, because of which there will be palpitations, right? And at one point of time, when MR goes into a state of left ventricular failure, then these patients will have dyspnea. Okay, and MR will cause left ventricular failure. And you know what type of left ventricular failure you see in case of MR? It is heart failure with reduced ejection fraction. That is when there will be pulmonary edema resulting in the dyspnea in these patients, right? And in patients with MR, there is a regurgitation of the blood from LV to LA. At the same time, LA is receiving pulmonary venous blood. So LA, while emptying the blood into LV back again, LV will be receiving the MR blood and as well as the pulmonary venous blood. So thereby, what will happen to the LV size? LV size is increased, right? And what type of hypertrophy you will have here? Eccentric hypertrophy. The hypertrophy that you will have is the eccentric hypertrophy. So whenever there is eccentric hypertrophy, right, it is the volume of the ventricle which is increased, not the thickness of the ventricle. Because in aortic stenosis, I'll be discussing, there you will have concentric left ventricular hypertrophy, but here it is eccentric left ventricular hypertrophy. So the apical impulse, it is shifted down and out. And the type of apical impulse is hyperdynamic type of apical impulse. Hyperdynamic you have in two conditions. One, in case of the MR, you will have hyperdynamic, and even in AR, you will have a hyperdynamic type of apical impulse. Whereas in AS, it is the heaving type of the apical impulse, right? So this is about the apical impulse, right? Whereas in MS, what did we discuss? A tapping type of apical impulse, and it is not shifted anywhere. It is felt in the left fifth intercostal space, midclavicular line. But in MR, it is shifted down and out because of eccentric left ventricular hypertrophy, right? Then, how will be your first heart sound? It will be soft. Why? Because in MR, the mitral valves are not closing completely, and because of which only the regurgitation is taking place back into the left atria. So first heart sound will be soft. And there are multiple conditions where first heart sound is soft. Prolonged PR interval, you will have soft S1, right? Calcified mitral stenosis, you will have soft S1, right? And any conditions which are increasing the distance between the heart and chest wall, like you take in emphysema, obesity, right? And COPD, which is nothing but your emphysema, left-sided pleural effusion, left-sided pneumothorax, right? So in all these conditions, or like you take in case of pericardial effusion, in all these conditions, the distance between the chest wall and heart is increased, so thereby the intensity of the first heart sound is reduced. So the first heart sound is soft in patients with MR. Then you take P2. The P2 will be loud. Why the P2 will be loud? Because of pulmonary hypertension. Almost all the valvular heart diseases, that means left-sided valvular heart diseases, they cause pulmonary hypertension, because of which P2 will be loud. And the murmur will be pansystolic murmur, right? And this pansystolic murmur, it is heard at the axilla, which is a high pitch. So first, actually, it is heard at the apex, right? From the apex, it will be radiating to the axilla. And this murmur, it is a high-pitched murmur. This murmur, it is a high-pitched murmur, right? And it is best heard in the individuals, making the individual to lie down in the left lateral position. Right? So you need to make the individual to lie down in the left lateral position. Then you need to auscultate at the apex, where you will listen pansystolic murmur. Then what are the differential diagnoses for pansystolic murmur? So differential diagnosis for pansystolic murmur will be MR, then TR, then large VSD, right? And even MR and TR also, it is chronic MR and chronic TR. And MR murmur, it is heard at the apex, right? TR murmur, it is heard in it is heard at the left fourth intercostal space, right? Left fourth intercostal space. right? And then you take this VSD murmur, it is heard in the fifth left intercostal space, parasternal line, right? Parasternal line. Okay. And this MR murmur, it increases on expiration. TR murmur, it increases on the inspiration. Whereas VSD murmur, there is no change with respiration. And this TR murmur, which is increasing on inspiration, what is this sign called? This is called as the D. Carvalho sign. This is called the D. Carvalho sign. So this will be the differential diagnosis for the pansystolic murmur, AR, TR, and as well as the large VSD, right? Then next. So then followed by that, the third heart sound will be heard in patients with the MR. So along with the PSM, there will be third heart sound. But when will you listen to third heart sound? You will listen to third heart sound when the individual develops left ventricular failure. When the individual develops left ventricular failure, that is the point when you will have third heart sound. Then in case of acute MR, right? In case of acute MR, you will have this functional murmur, that is Carey-Coombs murmur, which is a mid-diastolic murmur, right? Which is a mid-diastolic murmur. So please remember, your Carey-Coombs murmur is heard only in acute MR, not in case of chronic MR. Done? So this is about the auscultation. So to compare the auscultation now, in MS, first heart sound will be loud. P2 will be loud, right? And in the diastole in MS, you'll have opening snap, mid-diastolic murmur, pre-systolic accentuation. Whereas in MR, the murmur will be the pansystolic murmur. It's a high-pitched murmur. Whereas in MS, it's a low-pitched murmur, right? So that is the difference, right? Next. Okay. Next is the workup. So what is that? The first investigation of choice in case of MR, that is your 2D echo, right? In the 2D echo, what is that you need to learn for? You need to learn for how is the valve, and you need to check the valve hemodynamics in patients with the MR. So these are the two things that you need to check. So, and you need to assess the CVRT of the MR based on 2D echo only. 2D echo will tell you how much is the regurgitation volume that is happening from LV to LA whenever there is LV systole, right? Now, one point I wanted to add here is, in case of the chronic MR, it is the pansystolic murmur. And even in case of chronic TR, it is the pansystolic murmur. Whereas in case of acute MR and in case of the acute TR and in cases of small VSD, in all these patients, remember, it is the early systolic murmur. Right? It is early systolic murmur in case of the acute MR, acute TR, and small VSD. So in chronic MR, chronic TR, and large VSD, you will have pansystolic murmur. Okay, so you should not get confused when it is early systolic murmur, when it is pansystolic murmur in case of MR. Then how do you treat these patients with the MR? Diuretics is what you need to give. Why? Because there is pulmonary edema, you need to treat that pulmonary edema, right? And see, basically these patients are lining up in heart failure, and you need to give all the drugs what we give in heart failure. Diuretics, beta blockers, ACE inhibitors, ARBs. What these reasons for which you need to give these drugs? Beta blockers, ACE inhibitors, and ARBs, they prevent the cardiac remodeling. ACE inhibitors, ARBs, and beta blockers, they prevent the cardiac remodeling and they reduce the mortality in patients with heart failure, for which you need to give. And when is that there is requirement of mitral valve replacement? When the ejection fraction is reduced to less than 60%, or when LV end systolic diameter, if it is more than 45 mm or more than 4.5 centimeters, that is the point when you need to do mitral valve replacement. Okay, so this is about the MR. So in case of MR, acute MR, infective endocarditis and the anterior wall MI or inferior wall MI. Chronic MR, rheumatic heart disease, dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, mitral valve prolapse syndrome. Acute MR, the patient will present with sudden onset dyspnea. Chronic MR, they present with palpitation first and followed by dyspnea whenever there is development of left ventricular failure. Right? The apical impulse will be hyperdynamic type of apical impulse, right, which is shifted down and out. And the auscultation, first start sound will be soft. P2 will be loud due to pulmonary hypertension. And you'll have pansystolic murmur in chronic MR, which is heard at the apex, that will be radiating to the axilla, and it's a high-pitched murmur. And you need to listen that murmur in the left lateral position. The investigation of choice is to echo, and treatment is diuretics, and along with that, you need to give the drugs which will reduce the mortality in patients with heart failure. And when ejection fraction is reduced to less than 60%, or when LV and systolic diameter is more than 45 mm, that is the point when you need to do mitral valve replacement. Okay, so this is about the MR. Next, coming to the AS, that is the aortic stenosis. So aortic stenosis, when do you call it as aortic stenosis? When the valve area is reduced to less than 2 centimeters square. Normally, how much is the gradient between the LV and aorta? Normally, the gradient between LV and aorta, it is less than 10 millimeters of mercury. Right? Normally, the gradient between LV and aorta is less than 10 millimeters of mercury. But in patients with AS, the gradient will be increased to more than 10 millimeters of mercury. The gradient will be increased to more than 10 millimeters of mercury in case of the aortic stenosis. Right? And what are the etiologies for the aortic stenosis? See, the most common cause of aortic stenosis in elderly individuals will be calcific aortic stenosis, right? Or the sclerotic aortic valve. Whereas in children, the most common cause will be the congenital aortic stenosis, where you'll have the bicuspid aortic valve. Right? Where you'll have bicuspid aortic valve. Okay. And in order to develop this bicuspid aortic valve, the mutation that will happen is the Notch gene mutation, right? Notch gene mutation. And the other causes for aortic stenosis will be rheumatic fever. So most common cause in elderly, the calcific aortic stenosis, whereas in children, that is bicuspid aortic valve due to Notch one gene mutation, right? And the other causes will be rheumatic fever. And there are some risk factors which will precipitate the aortic stenosis, like smoking, hypertension, and dyslipidemia. And what are the clinical features that you'll have in aortic stenosis? That is angina, syncopal attack, and the dyspnea. Right? Angina, syncopal attack, and dyspnea. Why? See, in these patients with the aortic stenosis, the valve area is reduced to less than 2 centimeters square. When valve area is reduced to less than 2 centimeters square, what will happen to cardiac output? Cardiac output will be reduced. Now, as the cardiac output is reduced, what will happen to cerebral perfusion? Cerebral perfusion is reduced, and that can cause syncopal attack, right? Next, now these patients, because of the aortic stenosis, right, left ventricle will try to increase its pressure to push the blood into the aorta. So that will result in left ventricular hypertrophy, and that too concentric left ventricular hypertrophy. Whenever there is concentric left ventricular hypertrophy, what will happen to myocardial oxygen demand? Myocardial oxygen demand is increased, right? So in patients with the AS, the demand will be more, the supply will be less. Right? Why demand is more? Because of concentric LVH. Why supply is less? Because of decrease in cardiac output. So demand will be more, supply will be less, and that will result in angina. And at one point of time, these patients will develop heart failure. What type of heart failure these patients will develop in case of AS? That is heart failure with preserved ejection fraction. So whenever they develop heart failure with preserved ejection fraction, it is a diastolic dysfunction, and that can make the individual to develop dyspnea. Right? So this is your ASD. And always remember, symptomatic aortic stenosis, the prognosis will always be bad. Right? Symptomatic aortic stenosis, the prognosis always will be bad. Right? Symptomatic aortic stenosis, immediately you need to do aortic valve replacement. That is a primary treatment. If it is asymptomatic, you can give medical management. But if it is symptomatic, you need to do aortic valve replacement. Okay. Next, coming to the apical impulse, you will have heaving type of apical impulse. Right? And this heaving type of apical impulse, it is felt in fifth left intercostal space, mid-clavicular line. Right, where you'll have sustained uplift of the finger. That is called heaving type of apical impulse. Right, and the characteristic pulse will be pulsus parvus et tardus. What is this pulsus parvus et retardus? Where you have a slow rising pulse with late peaking is called as the pulsus parvus et retardus. Slow rising pulse with late peaking is called pulsus parvus et retardus, right? And here the cardiac output is reduced. That is the reason why the systolic blood pressure will be reduced. That is the reason why systolic blood pressure will be reduced. Now, as the systolic blood pressure is reduced, what will happen to the pulse pressure? The pulse pressure also will be down. Pulse pressure also will be down. So on examination, these patients will have pulsus parvus et retardus, systolic decapitation, narrow pulse pressure, right? And the next important is heaving type of apical impulse. Then if you take auscultation, first heart sound will be normal in these individuals, but the abnormality will be in the second heart sound. Okay. So you take in case of AS. Aortic stenosis, I am discussing the auscultation. This is the first heart sound, second heart sound, and again first heart sound. Okay, so this will be the systole, right, which is only 0.3 seconds, and this is diastole, which is 0.5 seconds. Okay, so in this, the A2 will be soft, and you will listen a murmur, and this murmur will be mid-systolic murmur. This murmur will be mid-systolic murmur, and this mid-systolic murmur, in case of AS, it is heard in second right intercostal space. It is heard in second right intercostal space, right? And this murmur, which is heard in second right intercostal space, it is harsh ejection systolic murmur, and it is a low pitched murmur in aortic stenosis similar to MS, and this will be radiating to the carotids, right? This will be radiating to the carotids, right? And the murmur of the aortic stenosis, it can also be heard at the apex, right? The murmur of the AS, it can also be heard at the apex. So if the murmur of aortic stenosis, if it is heard at the apex, it is called as Gallawerdin phenomena, right? So this is called as Gallawerdin phenomena. Okay, so this is about the AS murmur. It's a mid or ejection systolic murmur. Now, what are the differential diagnosis for mid or ejection systolic murmur? Differential diagnosis will be PS and then HOCM, right? PS and HOCM, right? And it's a low pitched murmur, and that will be radiating to the carotid, right? And it is also heard at the apex, in the sense it will radiate to the apex, right? The murmur can radiate to the apex, and that is called Gallawerdin phenomena. A2 will be soft. Why? Because it's a calcific aortic valve. A2 will be soft. And what is the additional sound that you listen? You will listen the S4. You'll have the S4 is nothing but atrial gallop. Whereas in MR, what did we discuss? In MR, you will have S3, that is ventricular gallop. Whereas in AS, you will have S4, right? AS, you listen S4. Okay, so this is about the auscultation in case of the aortic stenosis. Then, how do you evaluate the patient of the aortic stenosis? The investigation of choice will be 2D echo. Right? So please remember, in all the valvular heart diseases, the first line investigation will be 2D echo only. Right? Now, 2D echo in AS, depending upon the valve area, we classify it into mild, moderate, and severe. So the first parameter that we take is valve area. So if the valve area is 1.5 to 2 centimeters square, we call it as mild. When valve area is 1 to 1.5 centimeters square, we call it as moderate. When valve area is less than 1 centimeter square, we call it as severe. Then the next parameter that we take into consideration is the gradient. Right? Now, if the gradient five minutes less. right? So now in case of, so if you take the gradient, in case of mild, the gradient between LV and iota, it is less than 25 millimeters of mercury. Whereas in moderate, it is 25 to 40 millimeters of mercury. Whereas in severe, the gradient will be more than 40 millimeters of mercury. Then the other parameter that we take into consideration for assessment of the CVRT is the aortic jet velocity, right? So if you take the aortic jet velocity, in mild, it is less than 3 meters per second, right? Less than 3 meters per second. How much is normal aortic jet velocity? Up to 2 meters per second. Whereas if the aortic jet velocity is less than 4 meters per second, it is moderate AS. And if the aortic jet velocity is more than 4 meters per second, then it is called as the severe aortic stenosis, right? Severe aortic stenosis. So this is about the 2D echo assessment for the AS. How do you assess the severity? Then when you do ECG, ECG will show you that there is a concentric left ventricular hypertrophy. And that, how can you make out that it is a concentric left ventricular hypertrophy in the ECG? You have a criteria that is called Sokolov-Lyon criteria. Right? It is called Sokolov-Lyon criteria. Sokolov-Lyon criteria is nothing but where the amplitude of SV1 plus RV6, it will be more than 35 mm. Right? It will be more than 35 mm. Then what does the chest X-ray shows? The chest X-ray will show you that there is pulmonary congestion. There is pulmonary congestion. Why? Due to pulmonary edema. Then how do you treat these patients with AS? What did I tell you? If the patient is having symptomatic AS, you don't have any other option except for surgical treatment. And the surgical treatment options are the TAVR, that is transcatheter aortic valve replacement, or the SAVR, which is the surgical aortic valve replacement, right? And if the individual is asymptomatic, medical management is required. But what are the indications for surgical management in asymptomatic aortic stenosis? Number one, if the patient is planned for CABG and also has the AS, do aortic valve replacement. Ejection fraction less than 50% asymptomatic, AS is there, aortic valve replacement should be done. Gradient more than 55 millimeters of mercury. Failure of systolic blood pressure to rise more than 20 millimeters of mercury. And severe valvular calcification. So these are the indications where you need to do aortic valve replacement even though the individual is asymptomatic, right? And always remember, if a patient with AS becomes symptomatic, the prognosis is very bad. The prognosis is poor prognosis, right? So this is about the AS. So please remember 3 important symptomatologies: angina, syncopal attack, and then dyspnea, right? And auscultation is very important, where your A2 will be soft, right? And the next important is the ejection systolic murmur is being heard. And in case of AS, okay, in case of AS, if you take the auscultation, right, that is, you need to make out the split as well in second heart sound. That is A2, P2 split, right? So in case of mild AS, A2, P2 split will be narrow. You'll have narrow split of A2 and P2. Whereas in moderate AS, right, moderate AS, A2, P2 will be single. Okay, right? You'll have single S2. You'll have single S2. Whereas in severe AS, you'll have the paradoxical split. You'll have paradoxical split where P2 followed by that A2 will be there in case of severe AS. So this is the auscultation in case of AS. A2, P2 split. It's second heart sound. Now, after having discussed about the AS, the last one is the AR. Now, if you take this AR, aortic regurgitation, what are the etiologies for AR? Again, AR also, you have acute AR and as well as the chronic AR. What are the causes for acute AR? The infective endocarditis, it is the one which will be causing the acute AR. Then the another important condition where you will have acute AR along with infective endocarditis is the aortic dissection, right? Aortic dissection. These are the causes for acute AR. whereas the remaining all rheumatic fever, hypertension, bicuspid aortic valve, ankylosing spondylitis, Ehlers-Danlos syndrome, osteogenesis imperfecta, syphilis, all these will be causing the chronic AR. So acute AR, it is observed in infective endocarditis and as well as the aortic dissection. Right? Then what will be the clinical manifestations? So if it is acute AR, same like your acute MR, you will have sudden onset dyspnea. So acute AR, acute MR, they'll have sudden onset dyspnea. Chronic AR or chronic MR, the first important will be palpitations. Followed by that, you will have angina. Followed by that, they'll be having dyspnea. Okay. So why they'll be having dyspnea? That is due to pulmonary edema. Why there is pulmonary edema? That is due to heart failure. And what type of heart failure you will have in AR? That is heart failure with reduced ejection fraction is what you will observe. Right? And the palpitations, what could be the reason for palpitations? Because these patients will have eccentric left ventricular hypertrophy. And that hypertrophied left ventricle is arrhythmogenic and that will be causing palpitations. Right? And the angina also, these patients, they will be having nocturnal angina. And the type of apical impulse is hyperdynamic type of apical impulse. Why? Because it's eccentric hypertrophy. In MR and AR, it is hyperdynamic type of apical impulse. And next is in chronic AR, if you take the characteristic pulse, you will have Watt-Hammer pulse, right? Which is also called collapsing pulse, which is also called Corrigan's pulse. And systolic blood pressure will be high and diastolic blood pressure will be low. And this will result in the wide pulse pressure. Right? So this will result in wide pulse pressure. Okay? Right. Then single S2 will be there. Why single S2? Because in aortic regurgitation, the aortic valve is not closing. So the only second heart sound that you will be listening is P2. Right? And what is a true murmur in these patients with AR? The true murmur in patients with AR will be the early diastolic murmur. And this early diastolic murmur, it is the high-pitched murmur. And where is it best heard? That is in the Erb's point. That is in the third left intercostal space, parasternal line. In the Erb's point, this murmur is being heard. Right? And in order to listen to this murmur, you need to make the individual to sit down and lean forward. And then you place the diaphragm over the third left intercostal space. There you listen the murmur significantly. Then next is the Cole-Cecil murmur. Right? So Cole-Cecil murmur, it's a functional murmur. Right? It's a functional murmur. Right? Where the murmur of AR will be radiating to the axilla. Next is Austin-Klein murmur, which is a functional mid-diastolic murmur. Right? Then the mid-systolic murmur, that is also because of the functional aortic stenosis. So you have only one true murmur, that is early diastolic murmur. There are three functional murmurs. Cole-Cecil murmur, Austin-Klein murmur, and then mid-systolic murmur. These three are the functional murmurs. Right? Next. Next is the 2D echo is considered as the investigation of choice. ECG will show you that there is eccentric left ventricular hypertrophy. So what is the difference? In case of concentric, you will have SV1 plus RV6 more than 35 mm, whereas in eccentric hypertrophy, along with SV1 plus RV6 more than 35 mm, you will have deep Q waves. And where are these deep Q waves? These deep Q waves will be there in the precordial leads. And chest X-ray will show you that there is cardiomegaly and there is eccentric hypertrophy causing cardiomegaly, where the cardiothoracic ratio will be more than 0.5. And NT-proBNP levels, they are elevated. Why? Because there is eccentric left ventricular hypertrophy and heart failure also. That is the reason why NT-proBNP levels, they are being elevated. Right? And how do you treat these patients? You need to give diuretics, ACE inhibitors or ARBs. But please remember, in case of AR, you need to avoid the beta blockers. Why is that you need to avoid beta blockers? Because the regurgitation is happening in AR during the diastole of the left ventricle. What the beta blockers will do? Beta blockers will increase the diastolic time. So regurgitation can increase. So beta blockers are avoided. Then what are the indications for surgical treatment? The surgical treatment indications are: number one, LV ejection fraction reduced to less than 55%. Right? Number two, LV end diastolic diameter increased to more than 65 millimeters of mercury. Right? Number three, LV end systolic diameter is more than 50 millimeters. So these are the indications for surgical treatment. Okay, so this is about the AR. So, but please remember, AR also you'll have acute AR and chronic AR, and all the peripheral signs, right? Like your Quincke sign, the Corrigan sign or Corrigan's pulse, right? Locomotor brachialis, then dancing carotids, Demusset sign, then Landolfi sign. All these peripheral signs are present only in chronic AR, but not in acute AR. That is very, very important. Please remember, all the peripheral signs, they are observed only in chronic AR, but not in acute AR. Okay, so this is about all the valvular heart diseases. So I'll show you some of the multiple choice questions. Please answer them. Yeah. So we will discuss 10 multiple choice questions. Yes, please answer this question. Yes. So we have a 55-year-old man presents with exertional dyspnea, angina, and syncopal attack. On auscultation, the ejection systolic murmur is heard in the aortic area, and that is radiating to the carotid. So what is the likely diagnosis? Yeah, so it should be a simple question, not a difficult one at all. So there is an ejection systolic murmur, right? And this ejection systolic murmur, it is radiating to the carotid. It is very much suggestive of the aortic stenosis. Very much suggestive of the aortic stenosis. Okay, next one. Okay, so we have a patient with rheumatic fever, rheumatic heart disease, presents with loud first heart sound and opening snap, mid-diastolic murmur, right? So what do you think is the most likely diagnosis in this scenario? Loud first heart sound, then mid-diastolic murmur, and opening snap is being heard. Right, so here it is, the MS, mitral stenosis, okay, because it's a mid-diastolic murmur in case of MS. Whereas in MR, it is the pansystolic murmur. Whereas in AR, it is early diastolic murmur. Whereas in tricuspid stenosis, again, it is a mid-diastolic murmur. But like, why the answer being the mitral stenosis by not tricuspid stenosis? Why? Because the murmur is heard at the apex. In the apex, the murmur is heard in case of MDM. Whereas in tricuspid stenosis, the murmur is heard at fourth left intercostal space, parasternal line. Right, fourth left intercostal space, parasternal line. Okay, right. Next question. Right. So, which of the following valvular heart disease is associated with water hammer pulse and wide pulse pressure? Water hammer pulse and wide pulse pressure. So, water hammer pulse, which is also called collapsing pulse. Right, and this is also called as the Corrigan's pulse. This is also called as the Corrigan's pulse. So you listen that you'll have in case of the AR. But at the same time, this what are the differential diagnoses for the Corrigan's pulse? The differential diagnosis for Corrigan's pulse will be, or your water hammer pulse will be, all the hyperkinetic states. In hyperkinetic states also, you will have the water hammer pulse. Right, that is number one. Right, and the other conditions where you will have this water hammer pulse is in cases of the MR, chronic MR, you'll have water hammer pulse. And in case of large VSD, you can have water hammer pulse. In pregnancy, you can have water hammer pulse. Right? So these are all the differential diagnoses for water hammer pulse. It is not just observed only in case of the MR, not only in case of AR. Okay. So this is about your water hammer pulse. Right. So which of the following murmur is best heard in the left lower sternal border and increases with inspiration? Right, left lower sternal border and increases with inspiration. So which sided murmurs will increase on inspiration? It is the right sided murmurs which will increase on inspiration. And what is this sign called? This is what is called as the de Carvalho sign. This is what is called as the de Carvalho sign. Okay, and it is, the answer is the tricuspid regurgitation. Now the point is, why isn't it the pulmonary stenosis? Pulmonary stenosis you will not have in left lower sternal border. Pulmonary stenosis you will not have that in left lower sternal border. Pulmonary stenosis, it is heard at the second left intercostal space parasternal line. Right, second left intercostal space parasternal line. Okay, and aortic regurgitation, the murmur is early diastolic murmur. Right, whereas in pulmonary stenosis the murmur is mid systolic murmur, or which is also called ejection systolic murmur. Whereas in TR it is pansystolic murmur. Whereas in MS it is mid diastolic murmur. So your AR and MS, they increase on inspiration. Sorry, they increase on expiration. The murmurs increase on expiration, whereas the right-sided murmurs are the one which will increase on the inspiration. Okay, right. Next. So, which investigation is the gold standard for assessing the valvular heart disease? So, this should be a simple question, not a difficult one at all. So, don't go with the cardiac MRI. Don't go with the cardiac MRI. It is the 2D echo. Right? 2D echo is the one which will confirm. Okay. Next. A patient presents with the exertional dyspnea and palpitations. Right? And ECG shows atrial fibrillation with P mitral pattern. Which valvular heart disease is most commonly associated with these findings? Right, so this will be the MS. Right, in AS, what is that you will have? ECG, left ventricular hypertrophy will be there. Right, and this left ventricular hypertrophy, what did I tell you? SV1 plus RV6 will be more than 35 mm. Right, which is also called de-Carvalho sign. Right, whereas in AR, you will have the eccentric left ventricular hypertrophy. So that will give rise to the presence of the deep Q wave. Right, whereas in pulmonary stenosis, what is that you will have is right ventricular hypertrophy in the ECG. Right, and P mitral is observed in MS. That is because of left atrial enlargement. That is because of left atrial enlargement. Okay, right. Next. So, young adult with Marfan syndrome presents with diastolic decrescendo murmur at the left sternal border. What is the most likely cause? Yeah, so it is the aortic regurgitation. See, patients with Marfan's, they have connective tissue disorder, and that can make the individual to develop AR. And it's a decrescendo murmur which is heard in AR. Whereas in aortic stenosis, it is crescendo decrescendo. Right, it is crescendo decrescendo, and it's a diastolic murmur. Right, whereas in aortic stenosis, what is a murmur? It is a ejection systolic murmur. Whereas in mitral valve prolapse syndrome, it is late systolic murmur. Tricuspid stenosis, it's a mid diastolic murmur. So the condition where you will have decrescendo pattern is observed in case of the aortic regurgitation. In mitral valve prolapse syndrome, it is not the diastolic murmur. It is the late systolic murmur that you will have in case of, so mitral valve prolapse syndrome, they'll have mid systolic click with late systolic murmur. Mid systolic click with late systolic murmur. Okay. Yeah. Next question. So a patient presents with late systolic murmur and mid systolic click at the apex. What is the most likely diagnosis? Just now I was discussing. Mid systolic click with late systolic murmur. So where is that you will have mid systolic click with late systolic murmur? That is observed in mitral valve prolapse syndrome. Whereas in AS, what did we discuss? It is ejection systolic murmur or mid systolic murmur. MS, it's a mid diastolic murmur. Whereas in TR, it is a pansystolic murmur. Right? So MVPS, the most common clinical manifestation is palpitations, and drug of choice will be beta blockers. Drug of choice will be beta blockers. Okay. In aortic stenosis, which of the following findings indicate the severe disease? Transvalvular gradient more than 40, aortic valve area less than 1, pulsus parvus attitudus, all of the above. All of the above. Right? So gradient more than 40. Okay. Valve area less than 1, pulsus parvus attitudus. All these are the features of severe aortic stenosis. Right? Next. Which of the following is the contraindication for PBMV moderate mitral stenosis, LA thrombus, mild pulmonary hypertension, asymptomatic individual. Right, that is LA thrombus. So the PBMV contraindications, we have two contraindications or three contraindications. Presence of LA thrombus, right? Presence of moderate to severe MR, right? Moderate to severe MR. And the third scenario is calcific mitral stenosis. So these three scenarios, we don't do the PBMV. In these three scenarios, what we do is mitral valve replacement. Okay. So moderate MS, if the individual is symptomatic, we do PBMV. Mild pulmonary hypertension, like if we do PBMV, the pulmonary hypertension can decrease. Okay. So this is about the valvular heart diseases, right? So with this, we are done with the today's topic, where I've tried to summarize all the important valvular heart diseases, and then along with the multiple choice questions. The PDF will be uploaded along with the link will be uploaded. The PDF link will be uploaded. You can download that. Okay. So thank you very much. See you tomorrow again at 6 p.m. Severe aortic stenosis, right? Scenario A, we do is we do PBMV, the pulmonary hypertension. With this, we are done with the today's topic, where I have tried to summarize all the important valvular heart disease.